Hey, my name is Katie Tallis, and I am taking special education 683 fieldwork coursework section 811 with Dr. Henderson in the fall semester 2024. I am here to talk about a client of mine that I've been working with this past semester. Um, the objective of this presentation is to demonstrate understanding of assessment procedures, behavior functions, and rationale for chosen assessments. So basically, we're going to walk through the client selection, background, the assessments that were chosen, the results, and how this ties back into the task list items. So for the client selection process, I selected a client I've worked with extensively over the past few weeks. We have about 3 to 5 sessions together per week, and I ensured that there was assessment documentation for acquisition skills, maladaptive behaviors, and barriers for this client. The client will be referred to as EdLu or the client throughout the remainder of the presentation to maintain his confidentiality. So a little background, he is 9 years old. His diagnoses include autism spectrum disorders, apraxia, and an intellectual disability. The main behaviors of concern that we have are self-injurious behaviors, which are his head banging, mouthing, and finger tapping on dangerous surfaces. The assessments that I reviewed were the VB-MAP skills assessment, VB-MAP barriers assessment, discharge paperwork, and previous treatment plan. The rationale for using these treatment plans or for these assessments, what or yeah, these assessments and these tools was that he was a client that came to us from another ABA center, so we did have to review the paperwork and previous treatment plan. Um, to kind of see where he was at previously and what behaviors they were focusing on and what skills they had been previously targeting. And then we actually performed our own BBMAP skills assessment and barriers assessment to then kind of assess where he is and see how that compares to the targets that they were working on. Um, the VB map and the skill acquisition and barriers assessment was actually chosen because he has so few skills and does not typically up with his other typically developing peers. So we're not going to use something that's more in his age range. We need something that's targeting a lot of those early manding skills and communication skills since he doesn't have a consistent mode of communication. Um, the assessment results. So on the VB map, we identified very few milestones mastered in level 1 and none in level 2 and 3, which the VB map only goes to about 48 months. So he is very low, especially where he should be, compared to his typically developing peers. So this was obviously a concern of ours. And he's probably testing very low, even if he has some of these skills in his repertoire because of his barriers. So there were 21 areas where he tested relatively high in the barrier section, which affects how uh, impacted he is by these deficits, which they're occurring almost completely all of the time or pretty frequently. Um, His treatment plan identified problem behaviors and at what rate they were occurring a day. So we did have some of that. We had more behavior data than you can usually gain in a assessment, because it's just a 1 day kind of thing. So that was a really nice history for us to look at. And then my BCBA also had written a BIP, so that helped gain some idea of functions because we didn't have a formal assessment, like a FA or an FBA to look at. So integration with the BACB task list, the record review, I reviewed all of the documentation available. This was actually pretty difficult because he was a transfer from another client, so we were kind of working on some of the skills from the last treatment plan and kind of wrapping those up while also targeting some things that we feel like we need to work on. Um, the second area is determine the need for services. So he clearly already has services, but just where he's scoring compared to where, children who go up to 48 months are scoring on the VB map, he's very low and he's very low compared to his peers. So these intense behaviors and low ac skill acquisition are definitely a need for services. Socially significant behavior change goals. I were definitely identified in the treatment plan and barriers, and I selected based on intensity and safety of the client. So the functions of behavior were definitely identified in the BIP as escape, access, and automatic. So FA, interpret the FA data. There was actually not an FA completed. We did have the BIP, behavior intervention program, to provide some information. And then I also have a lot of experience working with this client consistently over the last several months. So I chose self-injurious behaviors, mouthing, and finger tapping as the most important things. The behavior goals that I ended up writing for him were client will decrease self-injurious behaviors to 0 instances per day across 30 consecutive days because these are pretty intense behaviors and head banging can lead to some severe injuries. I wanted this to be 0, and I do want to see it decrease, like stay consistently that way for 30 days. And then we have mouthing. So the client will decrease mouthing to less than 1 instance per day across 30 consecutive days. Mouthing, I'm okay with happening just like 1 time a day. He does have a chewy. We are using replacement behaviors for this, so I think it's important to, I don't know, even we as adults, and we sometimes, will chew on our fingers or bite fingernails, these sorts of things, like put a pen in our mouth. I don't think we need to completely get rid of mouthing altogether for him, but some of the items that he could put in his mouth can be dangerous, and he'll sometimes like chew on hard pieces that could break into more and then possibly be dangerous. So it is our goal to decrease it and at least replace it with a functional item. Um, Finally, finger tapping on dangerous surfaces. So the client will decrease finger tapping to less than 3 instances per day across 30 consecutive days. This is a behavior that happens at pretty high rates. Um, we're talking anywhere from 10 to 30 times a day. We have seen it decrease in intensity, but it's still happening quite frequently. He does not have some of the scarring and, um, cuts that he was getting before. But so light tap, we're shaping it to light tapping. But there are some more appropriate ways we can, hopefully um, move this to finger fidgeting. So I don't need this to go completely away. I just need it to be less dangerous for him. Um, yeah, and that is my presentation. Thank you for listening to this case study. Um, I hope you have a good night.